And then let me share my screen. Okay. So let's see, we should be seeing now, hopefully. Not sure if I can see that, but let's see if we are. I just want to be sure I'm sharing. Thank you. I'm so sorry. Got a lot of things open, so I want to be sure I'm sharing the correct one. Okay, very good. Perfect. All right, my friends. So just want to start off with something relatively basic and perhaps that you've heard me talk about before, and that is the basic evaluation at the bedside when we're looking at patients and trying to coordinate and understand, did the oxygen that I'm administering the patient, and typically we look at this when a patient is intubated, so that's really important. We're going to use it primarily when we are evaluating intubated patients. We look at something called the P to F ratio, looking at the oxygen in the blood related to the oxygen that you are administering. And of course, when we've intubated a patient, we're delivering it down an ET tube. We feel very certain that it should get to the place where gas exchange takes place, and that's the alveolus. This is known as the P to F ratio, also known as the PaO2 to FiO2, or the PF ratio. So you might hear it called PF, P to F, PaO2 to FiO2. What it does is it takes the patient's PaO2 from the blood gas and divides it by the FiO2 that you're administering. So it helps us to understand much more than simple PaO2. What it helps us to understand is, does the gas I give the patient get into the blood? Now, remember, I've said to you, really, you measure this on an intubated patient, but just for this example, we're just looking at a patient who is on room air, that's 21 or 0.21, and their PO2 is 60. So we take 60 and divide it by 0.21. That equals a P to F ratio of 285. Now, we always would like to see a P to F greater than 250. And in critical patients, anything less than 150 is really, really concerning to us. So although their PO2 might be 100, if they're on an FiO2 of 100%, that's 1.0, that's a P to F of 100. That means the gas you think you're delivering to the patient is not getting in the appropriate proportion into the blood. So now we look at patient 2 on mechanical ventilation, so intubated, and look, if you compare the PaO2 of patient 1, 60, to the patient 2 on the ventilator to 90, you're going to say that patient looks much better, except this patient has an FiO2 of 50%, 0.5. That gives me a P to F ratio of 180. So this patient is actually better than this one because the gas I'm giving the patient, or the gas the patient is taking, is getting into the blood. And here, the gas I'm giving the patient isn't really accurately and adequately or proportionately getting into the blood. So one of the first things is, when you're communicating with your colleagues, you should always know the P to F ratio on your patient. PaO2 divided by FiO2. You and I have one, ours is somewhere 300, 400. If I got put on 100% FiO2, my PaO2 would probably be 500 because the gas you give me gets into my blood. So we look at this proportional ratio, and it gives us a lot of good information about what we're going to do. So now we just say, okay, I have a patient with a PaO2 of 81 divided by an FiO2 of 0.70. By the way, I'm going to have to calculate it, and you can calculate it too. Pull out your iPhones, just do a quick calculation. 81 divided by 0.7, and that equals a P to F ratio of 115. Now, you may have been working all day to get that PO2 to 81, but you're using 70% FiO2, and the P to F ratio is 115. Remember, it's the PaO2 divided by the FiO2 in the decimal. So now let's do the next one. And again, I would encourage you to do it yourself at the same time I'm doing it. Take your patient's PaO2 100 and divide it by 0.8, which is 80% FiO2. And that equals 125. That's still pretty bad. Even though the PO2 looked okay, the P to F ratio is really poor. And then we take a look at our patient here, and we say PaO2 is 65 divided by the FiO2 of 0.21. Despite the fact that the PaO2 is 65, the P to F ratio is 309. So what that means to us is the patient who has a PO2 of 65 and an FiO2 of 0.21, who has a P to F of 309, guess what? They're an oxygen responder. These two patients are not oxygen responders. So what we're, oh, sorry about that. So what we're going to do is take a quick look at this. And what I'm going to do is stop sharing here. And then I'm going to start sharing on my simulator. Okay. So on my simulator, what you're going to see on the simulator is this visual, and this will be an ongoing visual, a live visual, should be a live visual. Oh, darn me, it doesn't appear to be live. So let me close it and come right back. So sorry, but we'll share it in 1 second when I get it back. I think I had multiple windows open, so it just kind of stopped working. So that's okay. So we'll go to our simulator and the X lung. We can take a look at our X lung. And now I'm going to share my screen. Okay, so now I'm taking a look at this patient. You can see his PO2 is 85 and his SAT is 96. So on your calculator, what I'd like you to do, if you don't mind, if you've got your calculator out, is take 85. Oh, I'm sorry, his SaO2 is 96. So let's look down here. His PO2 is 21. So 85 divided by 0.21 equals 404. Now, let's say that we're unhappy with that PO2 of 85 because I looked at your P to F and it was a good P to F. So it meant to me that the gas I'm giving you is getting into your blood. I'm just going to increase your FiO2. So I go up to 30. And what I expect to see almost immediately is that the PaO2 is going to start going up. Okay, so I've increased his FiO2 and look what happened to his PO2. And let's look at his P to F ratio. It stayed almost exactly the same. The first one we did was 404. The second one was 398. And let's just say we would never do this because we'd be pretty happy with that. That's pretty high. But let's just say we go up to 50%. So what you expect to see is not only that the PO2 goes up, but that the basic proportional ratio is going to stay the same. And that's a really important thing. Now, this is a simulator, so it doesn't always behave the way I want it to. So you can see your P to F ratio is 380. Remember, the original was 404. The next one was around 390. The next one is 395. Your patient is responding really beautifully to oxygen. Now I'm going to go back down. I'm going to go down to, I'll go down to 40%, and I'm going to confirm that. And you'll see that his PO2 will drop, but his PF ratio will stay relatively constant. So this is a really great way for us to say, should I give this patient more oxygen? Okay, so now what I'm going to do is I'm going to make the patient sick. I'm going to give him mild ARDS. And patients with a mild ARDS, we're going to look at their oxygenation. Okay, so you can see immediately his PO2 dropped and his PF ratio dropped as well. But what I also want you to note, and I'm sorry because before I did that, so let me go back. I'm so sorry. Sometimes when you're working with your simulator, you forget to point things out. I'm so sorry. So we're just going to go back here. We're back to the normal patient on 40% FiO2. He has a really high PO2, 154, not even greater at 160, might even go up a little more, and a PF ratio of 408. So he's looking pretty great. I want you to look down here at his peak pressure. His peak pressure, which means the pressure that is reached when you're blowing gas into his lung, his peak pressure is 21.75. So when I'm flowing gas in the lung, very little pressure is generated because my lung is beautiful, it's nice, it's compliant. Okay, so we're going to come back to that in just a minute. What I want you to see, though, I'm going to give this patient severe ARDS. We're not going to do anything else. I'm just going to show you. With severe ARDS, what you're going to see is your patient's oxygen fell. So I've made your patient sick, right? We're just on a simulator. And despite the fact that I'm on 40%, or even when I go to 100% FiO2, I'm not really going to get a very good response because in ARDS, the gas I'm giving the patient doesn't actually reach the lung. Okay, so the first thing I've done is at the ventilator, I put him at 100%. Okay, but what I'm going to see is the problem is that proportionally, the gas I'm giving the patient is not getting into the blood. So indeed, his PO2 had some response, not a great one. His P to F is really low, and that's primarily because the gas I'm giving the patient is not getting into the lung. That's the problem with pneumonia and pulmonary edema and ARDS. I've dialed lots of oxygen. I might even have a PO2 that I've worked hard to get to, but my PF ratio shows me that proportional ratio, which means did the gas I give the patient, that's FiO2, does that actually get into the blood? That's a life-threatening P to F ratio. So I'm going to stop here and I'm going to stop sharing. I'm going to reshare and I'm going to go back to the slides because I want to make sure we've got this good concept of, whoops, sorry. I'll stop sharing again because I think I went back to my X lung. I got confused myself, and I definitely don't want to confuse you. So now I'm going to just go back to my PowerPoint, and I'm just going to say we just looked at the P to F ratio, which remember says, did the oxygen that I'm delivering down your ET tube, does that actually appear in the blood? You have to have, normally you have a PF ratio greater than 250. Any PF ratio less than 150 is telling you that you are really, that your alveoli are not open. So now I just want to take a look at my ventilator and just remind you, depending on the ventilator that you work with, everybody works with different ventilators. This is the most common ventilator currently that we use at my hospital, Grady Memorial, and this is called the PB or the McKay or the Puritan Bennett, depending on what people say, but it's all the same ventilator. It's the 840, which is a very common ventilator. And you see down here, we have a patient with a PEEP of 5, and his FiO2 is 35%. Now, our assumption is, because of this appearance, is that our patient is actually oxygen responsive. He's only on 35% FiO2 with a PEEP of 5. Okay, so the next thing is when I have a patient who is not responding to oxygen, what I want to be able to do is measure what we call a plateau pressure. On your ventilator, now you're going to ask your therapist for this, but you want to understand it. I need a plateau pressure, please. Can you measure a plateau pressure? Your therapist will come, they press a hard key that says inspiratory hold. And what the ventilator says is, I'm going to flow gas into the lung, and then I'm going to close the exhalation valves, trapping the gas that I put into the lung. I can only do this in a volume control ventilation. Can't do it in pressure control, but I do it in volume control. Trapping the gas in the lung to actually look at the pressure that is generated. The bigger the lung, the lower the pressure. The smaller the lung, which means less compliant. I'm not talking about an adult versus a neonate. I'm talking about somebody that I'm concerned has ARDS. The bigger the lung, the lower the pressure with the same amount of gas that goes in the lung. But when the lung gets stiff and the alveoli are de-recruited, now the lung has gotten smaller because the alveoli are de-recruited, the higher the pressure, because now I'm putting the same volume in a much tighter vault. That's known as peak plateau. Plateau pressure says you took the volume of the breath, you disallowed the patient to exhale, and looking at the pressure that is generated when that volume is across all the alveoli. The more alveoli that are open, the lower the pressure. The less alveoli that are open, the higher the pressure. This is called the P plateau. And now we look at it again, we can just see P plateau. Here is your peak pressure. Here is your plateau. This is the difference between the two. And here you're looking at that plateau pressure again. That plateau pressure is 28. It's 28 here and it's 28 here. Okay. Now that's really important. When the breath goes in at the peak of the push in, that actually is your peak inspiratory pressure or peak airway pressure. That's 35. And when we've asked the vent to close the exhalation valves, that's because your respiratory therapist pressed inspiratory hold. The plateau is 28. Now, we would like to always see peak pressure less than 40, and we would like to always see plateau pressure less than 25. Now, I have a patient who's on 80% FiO2 or 100% FiO2, and they have a low P to F. The next step is to measure a plateau pressure. So now let's look at that. Okay, we're going to look at that plateau pressure. So again, I'm going to stop sharing. I'm going to reshare my simulation screen. Okay. And what we're going to do is we're going to go back to our patient who is normally just a normal patient with normal lung physiology. Okay, let me just mute that. That just is telling you the monitor. So we don't really care about that. We're just going to look at what's happening to the patient. He's nice and normal. He's breathing well. I'm going to put his FiO2 back down. Okay, I'll just put it down to 50. That's going to give him a high PO2, but we're okay with that. It just takes a long time. Let's see if I can just do it this way. I think I can. Okay, great. And I'm going to confirm that. Just this is my simulator. And you can see on 50% FiO2, my patient who has a normal lung has a PO2 of 400 or 287 with a beautiful P to F ratio. It's going to change a little bit with each breath, and it takes a minute for the patient to accommodate. So his PO2 is 219 and his P to F is 438. Now, if he suddenly dropped his PO2, you would go up on his FiO2 because he has a good P to F ratio. Okay, so now, and I want you to note down here, here's his peak pressure, 2164. Do I need to measure 21? We'll just say 21. Do I need to measure a plateau pressure on this patient? Absolutely not. He's got a great P to F and his peak pressure is low. I don't need a plateau pressure because the gas I'm giving the patient is getting in the blood. I'm assuming his alveoli are open. I'm assuming his alveoli are open. Okay, now I'm going to make him really sick because I want to make a really significant adjustment. So now I'm telling my simulator, mimic for me a patient with ARDS, severe ARDS. Okay, I'm not sure it did it. So let's, yeah, it did. Okay, great. So look what happened. His PO2 dropped. And more importantly, look at his P to F ratio. His P to F ratio is 99. By the way, don't waste time going up on his FiO2. Actually, you could go up on his FiO2 and it will make his PO2 better, but not really his P to F ratio. So of course, you're going to go up on his FiO2 because you're scared and you're worried and the patient's PO2 is really low. But look, I went up on to 70% FiO2 and I barely budged the PO2 and the P to F ratio is staying relatively constant. Now I go down here and I say, well, what's my patient's peak pressure? Now I always want peak to be less than 40 and I always want P to F to be greater than 150 and really greater than 250. So let's just say I want P to F to be greater than 250 and I want peak less than 40. My P to F is 78. My peak is high. It isn't always, but my peak in this case is high. I absolutely have to do a plateau pressure. Now, on my vent, I'm going to press a key called inspiratory pause, but here I have to make an inspiratory pause. So I'm going to confirm that. What you're going to see is the breath goes in and then it pauses. And this is plateau. And that plateau is going to appear over here. Okay. All right. Now, what's really important, my friends, is that my patient has a high peak, a low P to F, and a plateau pressure that's greater than 25. So now I've got to think about what am I going to do next? Because what I know clearly is that my alveoli are de-recruited when I'm putting the gas into the lung, the volume of gas into that lung, which should have been big, but now is small, or sometimes we call it baby lung. I have a high plateau and a low P to F. I can go all the way to 100% on my FiO2, and my PO2 is going to go up, but my P to F is not really going to improve. And what I now have to say to my therapist, to my doc, to everybody who'll listen, is we need to open up our patient's lung. And the way we open up the lung is through a mean airway pressure strategy. And for today, that will be PEEP. That is going to be incredibly and profoundly important. So let's just take a quick look at that. So let's, got to stop sharing and then reshare. So sorry. So we can look at our slides. You have to be pretty facile to go back and forth. Okay, so we should be back to sharing our slide. Great, excellent. All right, so now I just want to remind you that actually what we're going to do is we're going to keep volume of gas refreshed that stays in the lung all throughout expiration, not the end of expiration, throughout the whole expiratory phase. So in patients who don't respond to FiO2, whose P to Fs are low despite high FiO2, what we're going to do is we're going to apply PEEP, and we're going to want to apply PEEP as high as we need to. Usually we don't go higher than 25 until we see that we can reduce the FiO2 without losing oxygenation. Instead of having a small lung, we're going to open the lung, and we're going to open the lung using PEEP. So here you can see you've got a patient with a PEEP of 12.5. This is his PEEP plateau. And we've got a PEEP here of 12.5. It's the same thing on either side. You can look up here. We've dialed 12.5. He's got 13. That means he's got a little bit of trapping himself. And his PEEP plateau was 40. Okay. And I think this is one of the best things you could ever see. I really hate the discussion on it, so I'm going to turn that off. You're just going to see this is 5 of PEEP, and you can see a lot of the lung is not open. And now we're going to apply 10 of PEEP, and you're going to see more of the lung opens, right? So you started with a baby lung, and now we're going to be at 15 of PEEP. And now you see that the whole lung opens. Okay. Now, if I look at this again, at this point, I have a patient who on 5 of PEEP maybe is requiring 70% FiO2 to have an acceptable PO2 with a low P to F. Now I'm going to apply 10 of PEEP. I'm able to reduce the FiO2, and the P to F has increased because I have more functional lung. And now I'm going to add to 15 of PEEP. And I'm going to be able to reduce my FiO2 to 50% with a better P to F and a better PO2 because I have now opened the lung. I took that small lung, which you saw in the first visual, and made it a normal size lung. Once that lung is open, I can reduce FiO2. So you know that when you increase PEEP, if your patient's PO2 improves, you reduce FiO2 and they stay relatively constant or with a relatively constant P to F ratio, you've actually improved your patient's lung function. That's incredibly and profoundly important. So now let's take a quick look at PEEP and its application using our simulator. So I again want to remind you that it is a simulator and it's not a human being. And being a simulator, very similarly to being a human being, it doesn't always do what I want it to do. Okay, so I'm gonna have to actually log out and log back in. So it'll just take me 1 second. I go back to my X lung. So sorry. Oh, sorry. Go back to my X lung simulator. Just taking me a second, and then I will share it again. Here we go. We should be sharing. Okay, so now I'm going to go back and I'm going to make my patient sick. He's got severe ARDS. So with severe ARDS, pay attention to his peak pressure, pay attention to his PO2, and pay attention to his PF. So his PF was 85. He's on 21% FiO2, and his P to F is 406. Now, remember, this is a simulator, so I'm responding to what happens, but it's going to take me a second because I'm working with a simulator. Okay, so look at his PO2 and look at his PF. His P to F went down, 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 and his peak pressure is up, 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 up. So 2 things you're going to do. First of all, the quickest thing that we can do is we're going to put him on 100% FiO2, okay? And we're going to see that he really doesn't respond to 100% FiO2 because the gas I'm giving the patient is not really getting into the lung. And I know that because the next thing I'm going to do, or my therapist will do, is he's going to give my patient an inspiratory pause. So, okay, whoops, I don't want to do that. That's terrible. 5, okay, and I'm going to confirm that. So you're going to see right here, gas goes in and then gets trapped, and that gives us our plateau. And we're going to see that populate over here. That's your plateau pressure. Okay, beautiful. So once we do that, what we're going to expect to see is that our patient's gas exchange is going to improve. So let's see if that happens. It should. It's a simulator, so it may not always behave the way I want it to. I'm going to take my pause off. I'm going to go back to 0 here, because once you've done the plateau pressure, you don't need to do that anymore. But what we should expect to see is our patient's PO2 should start to improve because, well, no, he's not going to improve because I haven't adjusted his PEEP. So what I'm going to do now is I'm going to start to adjust his PEEP, which actually is going to open his lung. And I went up aggressively. You probably will go up between 3 to 5 centimeters water pressure. I went up aggressively because I want to show you what happened when I went up aggressively on his PEEP. His PO2 improved. His P to F didn't necessarily improve. Uh-oh, look at his peak pressure. It also went up. Peak pressure minus PEEP. So peak pressure is 50, but I've given him PEEP of 14. So I've raised his peak pressure because I'm giving him this much PEEP. Okay. Now, at this point, we're probably going to say we're going to put him on another form of ventilatory support. But what I wanted you to see is when I gave him PEEP, you actually saw that his PO2 improved significantly. So let me go back on PEEP, back down to 5. Okay. I'm going to confirm that. What I want you to see is I want you to see that his oxygenation falls. His peak pressure is also going to fall. Okay. But we have to use the PEEP to open the lung, otherwise he can't oxygenate. So quite honestly, we're going to have to do some other manipulation. The first manipulation that our docs might do is they're going to say, we're going to go down in his tidal volume, okay? And we're going to go up on his PEEP because he's looking terrible and we need him to be better oxygenated, but I want to keep his peak pressure down. So now I've gone up on his PEEP to 10, but down on his tidal volume to 350. And you can see that his oxygenation still improves, but his peak pressure doesn't go up quite as high as it did before. So that's one of the reasons we talk about low tidal volume. We're actually protecting our patient. Remember, he was up to 50. Now he's at 42. Now, I might still not like that, and I might choose another form of ventilatory support, something like pressure control. But what I was trying to show you here today is when you have a patient who is not responding to oxygen, and you know that because of PF, the next thing you think about is measuring a plateau. If P to F is low and plateau is high, there is no other option except to increase PEEP. As you increase PEEP, expect that your PO2 will improve. Your P to F might not improve that much, but your PO2 will definitely improve, and your peak pressure will also go up. So next week in simulation, we're going to talk about why we choose volume control versus pressure control. And we'll use the simulator again to help us actually visualize those changes as we are communicating about our patients. I want to say thank you for being wonderful and interested in improving your knowledge and your care for patients at the bedside. Today's talk was about P to F, peak pressure, PEEP plateau, and PEEP. And really, it's all about why do you add PEEP and what do you expect? When you add PEEP, you expect the PO2 to go up and you expect the peak pressure to go up. That means, though, that you might have to be concerned about how high that peak pressure is, and that's what guides us to alternative forms of ventilator support. So for today, that's the concept. When your patient is not responding to FiO2, and every day, actually, you should always look at a P to F. When your P to F is low, that means your patient is not responding to FiO2. Think about adding PEEP and be aware that when you add PEEP, the peak pressure may go up. Next week, we'll talk about what you do when the peak pressure goes up. Thank you very much for joining today. I'm going to say bye-bye for now, and that's bye-bye for the recording, but I'm going to stay online to answer any questions. Thank you very, very much for joining today.